Hello everyone, welcome to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Tariq, your host for today's episode, and I'm joined by Amro to discuss anorectal disorders and mesenteric ischemia.
Hello, Tariq. Great to be here. These disorders can be a mild, annoying inconvenience, but they could also be a life-threatening emergency.
Absolutely. Before we dive into specific conditions, let's set the stage. What's really happening when we talk about lower GI bleeding? What are the common causes, and what's the underlying pathophysiology?
Lower GI bleeding refers to any bleeding that originates from the colon, rectum, or anus. The causes are broad, but we can group them into a few key categories. Anorectal disorders like hemorrhoids and fissures, which are often due to increased pressure and straining. Mesenteric ischemia, which is like a heart attack, but for the gut, where blood supply to the intestines gets cut off. And finally, diverticular disease, where little pouches in the colon wall can bleed or get inflamed. Ultimately, it's either a disruption of the mucosal integrity, vascular compromise, or inflammatory damage. Whether it's a torn vessel, an ischemic segment, or an eroded diverticulum, the end result is bleeding into the GI tract.
Anorectal disorders are some of the most common reasons people see a doctor for lower GI issues. Before getting into cases, let's quickly review the relevant rectal anatomy that can guide us through diseases.
Of course. The rectum is about 15 centimeters long, starting at the level of the sacrum. The upper third is covered by the peritoneum anteriorly and laterally, while the middle third is only covered anteriorly. And then we have the lower third, which has no peritoneal covering. The anal canal is about 4 centimeters long. There's a specific landmark in the anal canal called the dentate line. This is where the simple columnar epithelium transitions into stratified squamous.
Okay, but who cares? Why does any of this matter?
This matters because nerve supply, vascular drainage, and lymphatic drainage change at that line. In general, anything above the dentate line is visceral, and anything below is somatic.
Okay, sure thing, man. Let's just get back to this idea later on. But for now, I think this should be pretty good. Let's start looking at our patients. We have Ahmed, a 45-year-old truck driver. He complains of itching and discomfort around his anus, especially after long drives. And recently, he started noticing bright red blood on his toilet paper.
So our patient Ahmed has hemorrhoids. What exactly are they, you may ask? Well, let me tell you. Hemorrhoids are dilated veins in the rectal or anal region. We classify them as internal versus external. Internal hemorrhoids are above the dentate line, because they are more inside, if you will, while external hemorrhoids are below the dentate line, so they are more external.
I heard that hemorrhoids can be really common.
Yeah, they are.
So, risk factors include pregnancy, obesity, prolonged sitting, chronic constipation, and straining. But my question is, when our patients come to the hospital, what are they usually complaining of?
They usually say they have itching, discomfort, pain, especially with external or thrombosed hemorrhoids. They may also have bright red bleeding, prolapse, and mucus discharge.
So, can we just diagnose it by inspection?
Usually, yes, by inspection and digital rectal examination. But we also use anoscopy to visualize and grade them.
So that's for diagnosis, but how do we manage hemorrhoids? I'm guessing we'd have to do something like treat underlying causes or something like that.
Yeah, that's a big part of management. Since the main underlying problem is constipation, we need to treat that by some lifestyle modifications, like increasing fiber and water intake.
Right. Handle the straining, and you get rid of the hemorrhoids.
Weight loss is also important, because we want to decrease the intra-abdominal pressure.
Since high intra-abdominal pressure is also one of the predisposing factors.
Exactly. Other than that, we can instruct patients to use sitz baths and lidocaine cream for pain.
So what happens if all of this just fails?
In that case, there are some specific management options depending on whether it's internal or external. For internal hemorrhoids, we can do rubber band ligation, sclerotherapy, or surgery. For thrombosed external hemorrhoids, we can go with surgical excision.
So rubber band ligation sounds fairly straightforward. Why not just spam it for all hemorrhoids? Why not give it for external hemorrhoids as well?
If you want the patient to die of pain, maybe. Just kidding. But yeah, basically, remember what we said about external hemorrhoids?
That they have somatic innervation?
Yeah, so anything with somatic innervation would be painful. Imagine constricting it with a rubber band.
Since internal hemorrhoids have visceral innervation, Patients aren't going to feel anything when you do rubber band ligation.
Exactly.
Alright, so let's test our listeners with a quick practice test. A patient presents with a painful purple protruding perianal mass. What's the likely diagnosis, and what's the treatment?
Like we just explained, this is a thrombosed external hemorrhoid because it's purple and painful. We'll treat it with surgical excision if all supportive measures fail.
Now let's consider Layla, a 28-year-old lady with severe sharp pain during bowel movements, followed by bright red bleeding on her toilet paper. It's so severe she's been avoiding going to the bathroom, and she was recently diagnosed with an anal fissure. Can you tell us what that is?
An anal fissure is a tear in the lining of the anal canal, usually in the posterior midline. Most are caused by trauma from hard stools or straining. They're common in young and middle-aged adults.
A tear in the lining sounds really painful.
It really is. These patients usually come complaining of severe pain during defecation. They may also have bright red bleeding and sometimes a visible tear or a sentinel skin tag.
So, when we're saying a tear in the lining, how deep is that exactly?
Chronic fissures may get so deep. They may actually expose the internal sphincter muscle.
Oh, all the way to the internal sphincter muscle. So, the main risk factor is constipation, right? All of that straining and the hard stools.
Pretty much, yeah.
So, the key in the management of anal fissures is going to be lifestyle changes and treat any underlying constipation. So, stuff like dietary changes, fiber, increased fluid intake.
They can also use sitz baths and lidocaine for pain.
Oh, so it's basically hemorrhoids part 2.
So far, yes. But we have some additional things like topical calcium channel blockers or nitrates.
How does that help?
They relax the sphincter to decrease some of the pressure on it.
Can we do anything else to relax the sphincters? Like, I don't know, say maybe Botox, for example?
Nice guess. We do actually use Botox injections for the refractory cases. Or if it's really not responding to anything, we perform a surgery called lateral internal sphincterotomy.
So you just cut the sphincter?
Yep.
That doesn't sound very good for the patient.
Well, as a last resort, you can go for it. It does have some advantages, like a more relaxed sphincter and better blood flow.
Okay, let's test our listeners now. So, what's the first line medical treatment for a chronic anal fissure?
Topical calcium channel blockers or nitrates to reduce sphincter spasm.
Perfect. Now let's move on to another cause of lower GI bleeding, which is perianal abscesses and fistulas. So, abscesses and fistulas are related, but they're still two distinct entities.
They often go hand in hand, but they're not the same.
So, let's discuss Khalid, who's a 30-year-old man without any prior medical history. And over the past 2 days, he's been having a severe throbbing pain near his anus, which worsens when he sits down. And now he's been developing a fever and chills, and on examination, there's a red, hot, and very tender swelling just to the right of his anus. It feels firm and it's been getting bigger, and so the doctors diagnosed him with a perianal abscess.
A perianal abscess is a localized collection of pus due to an infection of an anal crypt gland.
So it's an abscess of the anal crypt glands?
Yeah, this is actually an emergency that needs drainage.
Okay, but like, how do these glands get infected in the first place?
The classic mechanism is blockage of the ducts of these glands, leading to bacterial stasis and infection. Constipation is a huge risk factor, but they can also be seen in conditions like Crohn's disease or diabetes. Perianal abscesses are more common in males, so usually you would see a male patient presenting with acute, severe, localized pain, redness, swelling, and a fever. And on examination, you look for induration and fluctuance.
So fluctuance is that palpable sense of fluid under pressure. It's like you're pressing on a balloon that's full of water. But wouldn't the patient feel something when you touch it?
Oh yeah, definitely. The DRE often causes exquisite tenderness.
I feel like this presentation is pretty distinct, especially with the localized pain and the fever.
Yeah, that's why the diagnosis is primarily based on clinical presentation.
And since it's an abscess, I'm guessing incision and drainage.
Yep, exactly. The gold standard is incision and drainage. You make a cut, let the pus out, and often pack the wound to allow it to heal from the inside out. Antibiotics alone, without drainage, are useless for an abscess. unless there are signs of spreading cellulitis or sepsis.
But if an abscess does become complicated, it can progress to a fistula. But let's explore that a little bit further by meeting our next patient, who's Rasha, a 28-year-old woman with Crohn's disease. She had a perianal abscess drained about 2 months ago. The acute pain and swelling has resolved, but since then, she's had persistent, intermittent drainage of a small amount of pus or bloody fluid from a tiny opening near her anus. It's not very painful, but it's annoying and it won't go away.
This patient has an anorectal fistula. By definition, a fistula is an abnormal connection between two epithelial surfaces. An anorectal fistula is an epithelial-lined tract or tunnel that connects the inside of the anal canal, usually at the dentate line, to the skin outside. It's often a chronic complication of a previous or an inadequately drained abscess.
So fistulas form when an abscess cavity fails to heal completely after drainage, leaving that persistent pathway.
Yep, and like the abscesses, they're associated with constipation and are a hallmark of Crohn's disease.
So what are some diagnostic clues that we can look out for?
One of the key clues would be a history of a prior abscess, because that's usually what predisposes these patients to fistula formation.
And those fistulas would usually come with discharge.
Yes, the main symptom is chronic, intermittent, serous or purulent drainage from a skin opening, i.e. the fistula. You might see the external opening on inspection, or you might find the internal opening inside the anal canal if you perform anoscopy.
But if you can only find one opening, how would you find the other?
You can map it by probing the tract during an exam under anesthesia.
And what about the treatment of these fistulas?
This depends entirely on the fistula's complexity. For simple fistulas, which don't cross much of the sphincter muscle, you do fistulotomy, which is surgically opening the entire tract. On the other hand, for complex fistulas, which involve a significant portion of the sphincter, you would use a seton placement. Seton is a thread that you leave in the tract to allow drainage and promote healing. Other than seton, you can perform some advanced procedures like the lift procedure.
And since abscesses and fistulas are so closely related, how do we differentiate between them when it comes to clinical presentation?
An abscess is the acute painful infection. It's a collection of pus that needs to be drained urgently. Think hot, red, painful, and urgent. A fistula is the chronic complication. It's a tunnel or a tract left behind. Think persistent drainage after an abscess. You can have an abscess without a fistula if it heals completely, but a fistula almost always starts as an abscess that didn't fully resolve.
So, let's move up a little with Fatima, a 70-year-old woman with a history of chronic constipation. She feels a mass protruding from her anus when she strains, and she sometimes has mucus discharge and fecal incontinence.
She probably has rectal prolapse, which is when the rectal wall protrudes through the anus.
The full thickness of the rectum protrudes?
Yeah, the whole thing. This is common in elderly, multiparous women because their pelvic floor is weak. It's also seen in those with chronic straining or those who had pelvic surgery. I want you to remember the protruding mass with concentric folds. This differentiates it from hemorrhoids. You may also see mucus, fecal discharge, or incontinence. And if you perform a DRA on the patient, it may reveal a weak sphincter tone.
Okay, so just to recap, a protruding mass, concentric folds, and a weak sphincter tone. Alright, got it. How do you manage patients with a rectal prolapse?
So the first line would be conservative management, with fibers, fluids, and pelvic floor exercises.
So basically like everything else we've been discussing so far?
Yes. Then we may do minimally invasive procedures, like performing a perineal repair or encircling the prolapse with a mesh. But the problem with these minimally invasive procedures is the recurrence.
So do we have something definitive for them?
Yup, the last and the definitive treatment for prolapse would be surgery.
So we fix the rectum in place somehow so it doesn't fall?
Yeah, that's exactly what we do. We call that rectopexy, which is fixing the rectum to the sacrum. This is definitive, and usually the prolapse doesn't recur.
Alright, question time.
How can you distinguish rectal prolapse from hemorrhoidal prolapse on physical exam?
Rectal prolapse has concentric mucosal folds, while a hemorrhoid would show radial folds. That was a lot to cover. I feel like if you get a patient complaining of some anal discomfort, it's kind of difficult to tell exactly what's wrong. And so let's point out some differences between them.
Absolutely. Hemorrhoids are dilated veins, so think of bleeding, prolapse, and pain if thrombosed. Anal fissures are tears, usually in the posterior midline, so always consider them in patients with severe pain with bowel movements. Perianal abscesses are infections, so there will be a fever. We need to drain those properly. A chronic complication of an abscess is a fistula. The last one is rectal prolapse, which is a full thickness protrusion, so you would see concentric folds, and usually the classic patient would be an elderly multiparous woman.
All right, perfect. Let's move on to mesenteric ischemia. So, mesenteric ischemia is such a critical topic because it's a true vascular emergency. Amro, I know the classification can get confusing. I mean, there's acute versus chronic, occlusive versus non-occlusive, arterial versus venous.
Yeah, I know. Don't worry, we'll break them down. Think of it like 3 branches. First, the biggest branch is acute versus chronic. Acute means a sudden onset surgical emergency, while chronic means a gradual progressive insufficiency. Now, acute can be divided into 2 branches, vasoocclusive versus non-occlusive. Vasoocclusive is when there's a physical blockage of the vascular blood supply, while non-occlusive means there's no blockage. It's just poor flow to the bowel. Now, within vasoocclusive, we split it further. It's either an arterial blockage or a venous blockage. Finally, arterial occlusion can be either embolic or thrombotic. Embolic is when something traveled there through the blood and ended up getting dislodged there. So, it could be a piece of a distant thrombus that broke off and shot all the way to the mesentery. On the other hand, thrombotic is when the thrombus actually formed there in the mesentery.
So, if we look at it from the most broad down to the most specific, we start with acute versus chronic, and then under acute, it can be vasoocclusive or non-occlusive. And then when you're looking at occlusive, it can be arterial or venous. And finally, arterial can either be embolic or thrombotic.
Yes.
Okay, now that we've done a bit of a general classification, let's look a little bit more into detail. And let's take a case. We have an 80-year-old man that has untreated atrial fibrillation. And he comes in, he has a sudden, severe 10 out of 10 epigastric pain that started while watching TV. His abdomen is soft, but he's writhing in pain.
This is a case of acute embolic mesenteric ischemia. It occurs when an embolus, usually from the heart, travels and lodges in a mesenteric artery, most commonly the superior mesenteric artery, or the SMA.
So there isn't an actual embolus in the superior mesenteric artery. It just traveled there from the atrium.
Emboli can happen due to 3 things. First, there is atrial fibrillation, which is the most common etiology. The irregular rhythm in the heart causes stasis in the atrium and allows clots to form. This clot that formed in the heart can then shoot through the arteries all the way to the superior mesenteric artery.
So if you have a patient that you already know has AFib, and he's coming in with sudden severe abdominal pain, you have to think of acute embolic mesenteric ischemia.
Yup. Some other cardiac causes can also lead to a similar presentation. So think of things like post-MI mural thrombus, stasis due to mitral stenosis, or valvular vegetations like an infective endocarditis. Other than cardiac causes, another possible scenario is if a patient has some sort of hypercoagulable state. This scenario is less common, but still possible, because they can form clots anywhere.
And as we've mentioned, this is embolic. So, the clot probably formed somewhere else, then grabbed a passport, ran to the GI, and got stuck in the mesenteric vessels, probably in the SMA. This is unlike a thrombotic case, where the thrombus would be inside the SMA from the beginning. But why would a thrombus even form there? Is it like atherosclerosis?
Yeah, that's exactly it. If an atherosclerotic plaque ruptures, a thrombus can become superimposed on it and block the artery.
But how would you even tell them apart? How would you distinguish a thrombotic from an embolic case on imaging?
Thrombotic occurs at the SMA origin, with pre-existing atherosclerosis. Embolic lodges more distally in otherwise normal arteries.
Oh, okay. So if the SMA is already diseased and it's already full of atherosclerosis, and you can see the blockage in the proximal part of the artery, then it's thrombotic. But if the SMA looks healthy, it looks fine, and has a blockage that's more distal, then it's probably embolic.
Exactly.
Okay, let's pause for a quick question. What cardiac condition is most commonly associated with acute embolic mesenteric ischemia?
Atrial fibrillation. It's the classic association.
All right, I think we've covered arterial occlusion pretty well. Now let's take the next case. A 40-year-old woman on oral contraceptives presents with 3 days of crampy, diffuse abdominal pain. She had a DVT 2 years ago, and on physical exam, her abdomen is mildly distended and tender. What can you tell us from this case so far?
This is also mesenteric ischemia. However, I want you to take note of the onset, which in this case is subacute, not as acute as the previous case, and the patient's pain is milder. Also, a major hint for this case would be the history of DVT. All these clues make us lean towards venous occlusive mesenteric ischemia.
Wait, what's going on? What's the pathophysiology behind this?
When the veins are occluded, this would lead to a backflow of blood, which in turn would cause edema in the bowel wall, therefore diminishing arterial flow. Usually, this disease happens if the patient is in a hypercoagulable state, like cancer patients, patients who are on oral contraceptives, like our patient here, portal hypertension, or even thrombophilias.
So, a patient with a hypercoagulable state is more likely to have a venous occlusion rather than an arterial one.
Yep, just like they're more likely to have DVTs.
Alright, we've talked about all of the acute occlusions. Now let's see the other branch of acute mesenteric ischemia, where you don't have an actual blockage. Let's meet our next patient. A 68-year-old man in the ICU is being treated for septic shock. He's on high-dose norepinephrine to maintain his blood pressure. And over the past several hours, his lactate levels have been rising, and the team notices mild abdominal distension. He is sedated, but when they palpate his abdomen, he still grimaces.
This is a classic presentation of non-occlusive acute mesenteric ischemia.
So, unlike the embolic, thrombotic, or venous types, this one has no clot.
Exactly. By definition, there is no physical blockage. The ischemia occurs because of severe vasoconstriction and reduced blood flow to the intestines. The vessels themselves are open, but the blood simply isn't reaching the bowel adequately.
And this is happening because the patient's in shock.
Yes, this is most commonly seen in critically ill patients, exactly like our ICU patient here. When someone is in shock, the body activates a survival response. Because blood flow is so bad, it's trying to prioritize blood flow to vital organs like the heart, brain, and the lungs, rather than send it to the GI tract.
So, the body basically goes, forget about the gut, I don't need it right now, focus on saving the brain and the heart.
That's right. The splanchnic circulation, aka vessels going to the viscera and the gut, undergoes intense vasoconstriction. Blood is shunted away from organs that are considered non-essential at the moment, like the intestines.
So, when the bowel isn't getting enough blood, what happens exactly? Like, okay, there's ischemia, I get that. But where exactly? Which layer?
The hypoperfusion leads to a cascade of injury. The first part that becomes ischemic is the mucosa. Remember, the mucosa has the highest metabolic demand out of any other layer in the intestines. So that means it's the layer most vulnerable to ischemia.
Gotcha. So all of the absorption is happening at the mucosa. And what that means is that it needs the most ATP. And so if blood is cut off, it's the one that gets affected the most.
Exactly.
All right, so mucosal injury is still the earliest thing you'll see. But eventually, the other layers are going to become ischemic anyways, right? They still need the blood supply, even if it's not as much.
Yes, if the hypoperfusion continues, the injury keeps progressing deeper. Eventually, there's transmural infarction of the bowel wall, with ischemia to the full thickness.
And once the bowel wall is infarcted, the barrier containing all of the bacteria is lost.
Exactly. Bacteria can translocate from the gut lumen into the bloodstream, leading to sepsis and ultimately multi-organ failure.
This sounds very dangerous.
It is. And one of the biggest challenges is diagnosing it, because these patients are already critically ill.
So, when do you think we should suspect a non-occlusive ischemia?
The biggest clue is the clinical setting. These patients are usually very sick. They may be in the ICU with shock, whether septic, cardiac, or hypovolemic.
Okay, so as always, context is key.
Yes, the symptoms are often vague. You may see abdominal distension, feeding intolerance, or rising lactate levels because of all the ischemia and stress the body is under.
And I'm guessing physical exam isn't going to be very helpful because the patient's usually going to be sedated.
Exactly. The exam is often unreliable in sedated or intubated patients. That's why imaging becomes important to us in these scenarios.
And what imaging are we going to be using?
A CT angiography is the way to go because you want to find the exact area that's not getting vascularized.
And are you going to see the blocked vessels on CT angio?
No, remember, this is non occlusive. You don't have anything blocking the vessels.
Right, of course.
The arteries appear patent and open, but the bowel shows poor enhancement, indicating poor perfusion.
So, open vessels. However, there's poor enhancement in the bowel on CT angio because there isn't as much blood flow.
Correct.
Okay, what about treatment? What are we going to do?
The most important step is treating the underlying shock. That's why you had bowel ischemia in the first place. So we need aggressive fluid resuscitation, and we have to optimize cardiac output.
And are we going to use vasopressors to minimize the shock?
We usually try not to use too much vasopressors if we can, because they worsen vasoconstriction in the gut.
And yeah, we wouldn't want to worsen the bowel perfusion by trying to improve the shock.
Exactly. In some cases, intra-arterial vasodilators like papaverine can be administered. This directly relaxes the mesenteric vessels and can be life-saving.
But if some part of the bowel is just gone beyond repair, we're going to have to remove it. We can't just leave it there, obviously.
Yeah, surgery is only indicated if there is clear bowel perforation or necrosis. Unfortunately, though, many of these patients are too unstable for surgery, so it's a tough situation to be in.
And let me guess, the mortality is super high?
Extremely high, often greater than 80%.
All right, listeners, time for a quick test. What's the key treatment for non-occlusive mesenteric ischemia?
Treat the underlying shock and consider intra-arterial vasodilators like papaverine.
So far, everything that we've discussed has been acute, but mesenteric ischemia can also happen gradually over time. So let's take a look at a different case. We have a 65-year-old man. He has a history of coronary artery disease and smoking, and he presents with cramping abdominal pain that happens about 30 minutes after every meal. Over the past 6 months, he's lost around 20 pounds because eating has become so difficult.
This is a classic presentation of chronic mesenteric ischemia.
So, unlike acute ischemia, this develops slowly.
Exactly. Chronic mesenteric ischemia occurs due to progressive atherosclerotic narrowing of the mesenteric arteries, leading to chronic intestinal hypoperfusion.
Oh, so this is just the gut remix of coronary artery disease.
That's a perfect analogy. Another thing that is also similar to cardiac ischemia is that unlike acute ischemia, in chronic ischemia, there's time for the collateral circulation to develop.
So the bowel just adapts.
Yes, but only to a certain extent. Because if the demand for oxygen increases, there simply wouldn't be enough supply. At rest, the blood flow may be sufficient, but after eating, intestinal demand increases significantly.
And so, just like Napoleon's armies in Russian winter, the supply just can't keep up. And so that's why there's the postprandial pain.
Exactly. It's all because of the mismatch between supply and demand.
And it's kind of like angina, but in the intestines.
Yeah. It's actually sometimes called intestinal angina. Anytime these patients eat, they experience so much cramping abdominal pain 15 to 60 minutes after eating. So they become afraid to eat and avoid meals.
And that's where the weight loss comes from?
Exactly.
So, on physical exam, is there anything specific to look for?
Sometimes you may hear an abdominal bruit due to turbulent blood flow through the stenotic vessels, but you wouldn't see much else on inspection.
So, do we also confirm this with a CT angio?
Yes, CT angiography will show severe stenosis or occlusion of at least 2 mesenteric arteries.
Why 2 arteries specifically?
Because the mesenteric circulation has extensive collateral networks. Remember what we said about the bowels adapting by forming collaterals?
Okay.
Symptoms usually don't occur unless at least two of the three major arteries are affected.
By three major arteries, you mean the celiac, the SMA, and the IMA, right?
Exactly.
So it's just like how cardiac angina starts when around 70% of a coronary vessel is blocked.
The analogy just keeps getting better.
So, how do we treat chronic mesenteric ischemia?
First of all, we need to slow down the disease progression by managing the underlying conditions that contributed to the atherosclerosis. So it's important to give statins, antiplatelet therapy, as well as to counsel the patient for smoking cessation.
But obviously, for a definitive treatment, we have to restore the blood flow.
Correct. Revascularization can be done either through endovascular stenting or surgical bypass. Endovascular stenting is less invasive, but surgical bypass is more durable.
And unlike acute, this isn't really much of an emergency.
Yeah, it's usually an elective procedure unless it progresses to acute ischemia.
Alright, listeners, lock in. It's time for another practice question. How many mesenteric arteries need to be diseased to cause chronic symptoms?
2 out of 3. The celiac artery, SMA, and IMA. This is because of the rich collateral network that forms in chronic cases.
Alright, Amr, before my voice gives up, let's wrap everything up one last time and summarize everything.
Starting with anorectal disorders, the key anatomical landmark is the dentate line. Above it is visceral innervation. Below it is somatic, which explains pain differences. Hemorrhoids are dilated veins. Internal are above the dentate line, and external are below. They present with bright red bleeding, itching, prolapse, and pain if thrombosed. Management starts with fiber, fluids, reducing straining, and sitz baths, while severe cases may need rubber band ligation for internal hemorrhoids or excision for thrombosed external hemorrhoids.
And then we discussed anal fissures, which are posterior midline tears that happen because of constipation and straining. The hallmark is severe pain with defecation and bright red bleeding. Just like with hemorrhoids, management can include fiber, fluids, and sitz baths, but the first line medical treatment is topical calcium channel blockers or nitrates to relax the sphincter. In more severe cases, we might need Botox or sphincterotomy.
Perianal abscess is an acute infection of anal crypt glands, presenting with severe pain, fever, redness, and fluctuance. The gold standard treatment is incision and drainage. A fistula is a chronic complication of an abscess, and it's basically an abnormal tract connecting the anal canal to the skin, presenting with persistent drainage. Simple fistulas get fistulotomy, and complex ones get cetum placement.
Rectal prolapse, on the other hand, is when you have a full thickness protrusion of the rectum, and it classically happens in elderly, multiparous women with chronic straining. The key exam finding is concentric folds. Management starts conservatively, but the definitive treatment is surgical rectopexy.
Then we talked all about mesenteric ischemia, which we divided into acute and chronic. Acute embolic ischemia is classically due to atrial fibrillation, causing sudden severe pain out of proportion to exam findings. Thrombotic ischemia occurs from atherosclerosis at the SMA origin. Venous ischemia occurs in hypercoagulable states like OCPUs and causes subacute pain due to venous congestion.
Non-occlusive ischemia, on the other hand, happens in critically ill ICU patients that are in shock, where you have severe vasoconstriction reducing gut blood flow despite open vessels. The mucosa is injured first because of its high ATP demand, but it eventually can progress to a transmural infarction, followed by sepsis and multi-organ failure. The diagnosis is usually by CT angio, which will show patent vessels but poor bowel perfusion. Treatment here focuses on correcting the shock and using vasodilators like papaverine if needed.
Chronic mesenteric ischemia is due to progressive atherosclerosis and presents with postprandial pain, food fear, and weight loss. It's what we call intestinal angina. Symptoms usually require two of the three arteries to be affected. Those are the celiac, superior mesenteric, and inferior mesenteric artery. Treatment includes statins, antiplatelets, and smoking cessation to manage the predisposing factors. as well as revascularization to get blood back to the bowel.
So, the key takeaway is recognize the pattern. The common anorectal causes, like hemorrhoids and fissures, present with localized symptoms and bleeding, while mesenteric ischemia, whether acute or chronic, will usually have something like a vascular risk factor, and they can be life-threatening if missed. Well, everyone, we've covered a tremendous amount today. Amr, thank you for making these complex topics so clear and engaging.
It was my pleasure, Tariq.
And thank you all, the audience, for listening to PodBites. Don't forget to like and subscribe, and until next time. Whoosh.
هي السطر كله
هو
بيرفكت.
ليه وقف؟
هي نقطة يعني أنا مستغرب.
تمام اوكي.
The analogy just keeps getting better.
You keep getting better. So, how do we treat
هاي بالآخر بالبلوبرز نحط